This is a woman I took care of in the last few years. Okay, sorry. Yeah. So she was 63. She had genotype 1B, relatively high viral load, asymptomatic, had some fatigue like all our Hep C patients, normal exam, little ALT elevation, normal liver function, normal kidney function. She had had a previous EGD that was normal. On imaging of her liver, she had mild splenomegaly and a few small venous collaterals, and also 3 indeterminate lesions, which we'll come back to. I would say this is her case now, 2016. So this is where she is today. That's not where she started. 2012, did a liver biopsy, showed stage 2 fibrosis. She was asymptomatic, normal lab. Imaging was totally negative at that time. She was in a clinical trial. She was treated with declatosphere, so NS5A inhibitor. Asunapravir, we haven't heard that word this meeting, but she got asunapravir, which is a protease inhibitor, and some ribavirin, 12 weeks. And then after that treatment, she relapsed. So she had exposure to NS5A inhibitor and a protease inhibitor. Then in 2015, she had a FibroScan. It came in at 11.9, so somewhere F3, F4 by that particular method. She was asymptomatic, normal lab. And now she has a triple phase CT, and she has some areas of transient hypervascularity. Do you ever get that in your radiology reports from the radiologist? Fleeting vascularity. Anyway, she was quite anxious about all this, and she thought, oh my goodness, now I've got cirrhosis and I didn't have it before, and now I've got potential liver cancer. You better get rid of this virus now. So how many of you would consider retreating this patient? This would have been last year. We had quite a few options last year, but anyone here retreat this patient? No breath testing. RAV testing. Yes. Sorry. RAV testing. No RAV testing available either. Well, so what would you have recommended for retreatment if you did retreat? These were the options we had. Just Harvoni alone, ledipasvir, sofosbuvir alone. Ledipasvir, sofosbuvir combination, the three drug combination, samipravir, sofosbuvir combination, could add ribavirin, lengthen duration, or just wait. She wasn't about to wait.
1 plus 4.
1 plus 4 would be, so you'd go with 3 plus 4, 1 plus 4. Anyone go for 5? Any 5s out there? Anyone want number 5?
1, 4, 5.
Charlton's over here, 1, 4, 5. Who likes 1, 4, 5? Okay, we got 3, 4, 5, 1, 4, 5. Okay, so the point of this, of course, is that she's had exposure to both the NS5A and the protease inhibitors. So I just wanted to point out, you probably all know this, but this is just to show the cross resistance that happens. And here's asunapravir right here. So it's got the typical RAVs for NS3 protease inhibitor, which is R155 and D168. This isn't hers because we didn't have RAV testing for her, but this is what you would expect with her prior exposure. Now, she's a year or 2 after that. Probably she wouldn't have these in testing, right? Because in about a year after they've had protease inhibitor exposure, these RAVs disappear. The NS3 protease RAVs disappear. But you can see whether they got treated previously with boceprevir, telaprevir, samipravir, asunapravir, paritaprevir, viniprevir, very consistent quite consistent RAVs in the 155 and the 168 domains. And then with the NS5A inhibitors, it's basically the Y93 and then the 31 and 30 position that are shared across declatosphere, ladiposphere, and ombidosphere. So just to point that out to folks. So we did 145. Was that a good thing? You think?
Yes.
We did the right thing? All right. Thank you. That's not what she says. She was treated with this 24 weeks. Now, she did refuse ribavirin initially because she had previously had ribavirin. And she said, I don't want that drug again. It gave me a rash, and I got anemic. But then at about week 12, she's been RNA negative the whole time. Her viral load dropped very quickly. But she was getting nervous that I had recommended ribavirin and she refused to take it. So halfway through the treatment, she says, Dr. Everson, would you please add the ribavirin? So I did. Too late. But it was administered. She relapsed 12 weeks after stopping treatment. She is upset, not just because the treatment did not work, but now she figures that she is harboring the Hep C superbug. And not insignificantly in the US, she had several $1,000s in copays. Now, the other thing that, on the superbug issue, if you look at sofosbuvir, you'll notice that generally it's been stated that there's no sofosbuvir resistance that emerges during therapy. However, there is some emerging evidence that if you go into prolonged treatments with ineffective regimens which contain sofosbuvir, that is indeed the situation where you can get the S2A2T emergence. So right now we are doing the resistance testing. I don't have that to share with you. But anyway, that is a concern in this case that in fact we may have created a Hep C superbug in her case. So now we go back to the case a little bit here. She had this fibrosis stage and she had these transient hypervascularities. And you'll remember we did a triple phase CT and she had 2 lesions that were actually LR4 and 1 lesion that was LR3. Not definite for HCC, but suspicious in one case and in 2 cases and indeterminate in the other. So we are also dealing with this issue in this patient, and we've essentially, they're not definite in terms of local regional therapy or surgical resection, but now she came in and said, look, I've got this cancer now, I've got a donor. So in fact, we did actually talk to her about evaluation for liver transplant. She's not listed. So in terms of treating her hepatitis C now, we have a situation, let's say, for example, that she indeed does emerge with HCC. If that is the case and we list this patient and she has a live donor, how would you treat her? Would you treat her in preparation for live donation? Would you wait till after a transplant? And if you decided to treat her in this setting, would you use, what DAA regimen would you use? Would you use interferon? Would you use ribavirin? And how long would you treat? So here's some of the options that other people have discussed in reference to treating a patient like this. We have the combination of the sofosbuvir with another 4-drug regimen, so 5 drugs. Don't have any data in a patient like this who's been exposed and relapsed after both Harvoni, ribavirin, and a protease inhibitor, NS5A, ribavirin cocktail. But you've seen that. One thing I'd point out, that this will be a poster, I think, on Friday. In this experience, though, there's a patient down here, if I can find it, who had, if you look at NS3 RAVs, NS5A RAVs, and NS5B RAVs. Now, this was to sabuvir, not sofosbuvir. But you can see triple across here. There's several patients in here that have like resistance to all three of the inhibitors, RAVs to all three of the inhibitors, and still achieved SVR. So maybe something like that would work. And of course, the SVR rates were quite high, which will be reported, I think, Friday. And then you've heard about these other drugs that are in the pipeline. I don't think a dual approach is going to be the right thing for such a patient. You've seen things, results with grazoprevir, elbasvir, very high SVR rates. But again, with this particular agent, if you look over here at population sequencing, you'll see that there's a big drop-off in SVR rates in those who have elbasvir-specific RAVs. And when you treat, though, with longer duration and ribavirin, you can overcome it. But is that really relevant to a case like ours that's been exposed to 2 different DAA regimens and may have multiple resistance variants out there? This combination, I think, also probably isn't going to work for such a case. We know the SVR rates are high there, even in cirrhosis, but we have no experience with RAVs with that. So the triple regimens are what people are focused on for these cases that have RAVs to multiple inhibitors. And this one was the SWIFT, the SWIFT-C study, and this is the Polaris studies right here, which are ongoing, and then there's several in the pipeline as well. So I suspect we will have a triple regimen that might work in such a patient. Just to point out that the C-SWIFT was the first triple combination that got us excited about triple therapy because it worked in cirrhotics with as little as 8 weeks of therapy, so very potent. And of course, potency of a regimen is going to be key for treating multiply resistant patients in the future. This is the kind of the hope of the future for such a patient right now, which is sofosbuvir with second generation, third generation NS5A inhibitor, and pangenotypic protease inhibitor. But with a case like I've presented, we have all this data, we have all this experience, but we don't really have an experience that's quite equivalent to her. And like Evel Knievel, you can start off on a process sometimes and not know exactly where you're going to land sometimes. And of course, those of you who know the Evel Knievel story, it did not land well for him. And he had hepatitis C. So here's this case. She's sitting here with these 3 indeterminate lesions, 2 courses of DAA therapy, probably multiply resistant hep C. Luckily, I had a way out. She's in a particular offshoot of the Polaris study with triple therapy. So next year I'll let you know if it worked or not. She's been evaluated but not listed for transplant, and she calls me periodically to inform me her donors are waiting. Thank you very much.